Hello and welcome to this Practicing Clinicians Exchange podcast. I'm your host, Zachary Schwartz. In this episode, we talk to Dr. Jason Farley, professor and nurse practitioner at Johns Hopkins University School of Nursing. He'll talk about his recommendations on the best ways to implement new HIV PrEP guidelines based on his clinical experiences. For more information on Dr. Farley and for other podcasts in this program, visit the website at pce.is/prep. So let's get started and hear from Dr. Farley.
With the release of new guidelines for HIV pre-exposure prophylaxis in late 2021, healthcare providers are now tasked with implementing relevant changes within their clinics. Effective PrEP really hinges on patient adherence, and in my practice, I have found that a shared decision-making approach between patients and providers yields the most successful outcomes. When it comes to a patient thinking about starting preventative HIV treatment or therapy, the first thing I do is to say, perfect. Let's do that. And then I ask them, and we talk more about why they think PrEP might be right for them. I then continue the dialogue by asking them to provide a more holistic view of their sex life, with the main focus really being on sexual pleasure, not disease or disease prevention. We then discuss how HIV prevention can be integrated into their life so it is there to promote their overall well-being and their overall sexual health. I find that this approach demedicalizes treatment and empowers patients to discuss sex openly and to be proud about their decision to take control of their HIV prevention, while simultaneously shifting the focus of HIV prevention or HIV PrEP from a disease-specific frame to one around sexual health. Recognizing that patients can be concerned about their health while still engaging in acts of sexual pleasure destigmatizes the treatment process, reducing anxiety and increasing HIV PrEP adherence. Now, an important change in the most recent CDC practice guidelines is that in addition to obtaining fourth-generation HIV testing, it's critical that once a patient has initiated PrEP, that we also monitor HIV viral load. And although we are seeing how effective HIV PrEP can be when properly administered, viral load evaluations remain the key to early HIV diagnosis and prevention of resistance. Testing for HIV RNA levels should be performed in all patients on HIV PrEP during clinic visits, every 2 months for long-acting cabotegravir, and every 3 months for oral PrEP. Here's an example from my practice of why monitoring is crucial. I was a co-investigator within HPTN, or the HIV Prevention Trials Network Study 083, a phase 2b/3 study examining the efficacy of PrEP, the injectable form of PrEP, in HIV uninfected cisgender men and transgender women who have sex with men. I had a married heterosexual male patient who participated in the study, and his sexual history screening revealed that he was having sex with men outside of his primary married relationship with his wife. During a clinic visit, the patient tested positive for syphilis, and I ordered an HIV RNA test, as both infections tend to go hand in glove. Now, at the time of the syphilis diagnosis, the patient had no evidence of HIV. The antibody and viral load were negative. However, I asked the patient to return to clinic a week later just to be safe, because I know he had not disclosed sex with men to his primary partner. And I said, I want you to return in 7 days, and we're going to reevaluate this viral load simply because you had a high-risk sexual encounter. And despite, obviously, with injectable forms of PrEP, we were evaluating either sham injection and real Truvada or sham Truvada and real injection with cabotegravir. We didn't know what this patient was receiving. So 1 week later, after having an undetectable viral load with no antibody, the patient presented and had a viral load on that evaluation of 83,000 copies per milliliter, showing that, if you're not really attuned to the different types of risk the patient has and how you can intervene quickly. And in this circumstance, we were able to provide him his diagnosis, both treat him for syphilis and engage him in care for his HIV treatment, and hopefully, although not known, hopefully prevent transmission to his primary sexual partner or his wife. So I think this case study reaffirms the guidelines that HIV viral load monitoring should be performed alongside clinical care management regardless of our belief in the HIV PrEP efficacy that we are providing our patients. Following these guidelines, in my circumstances, for example, led to an earlier HIV diagnosis, which we hope in turn leads to not only his earlier treatment, but also the prevention of transmission through treatment as prevention to sexual partners. Now, PrEP right now is becoming much more accessible. It can be prescribed in a variety of different clinical settings, and it is important for clinicians to explore all options for prescribing these medications so that the most effective regimen can be matched to the patient. There are currently 3 PrEP options for most people, but only 2 for cisgender women. It's the responsibility really of us as clinicians to provide an overview of the pros and cons of each of these regimens so that the patient-provider decision-making can occur. And really going through and thinking about what option the patient, number one, might have insurance coverage for, but also based on comorbidities and background of the patient, their age, healthy aging considerations, as well as what we can use for cisgender women are critical. In addition, in my clinic, really think about providing a broader sexual health type of service. So we talk about all vaccine preventable diseases that can be associated with hepatitis B, hepatitis A, and others, monkeypox increasingly so now with many of my patients. But we also need to think about STI prevention. And so data from another trial suggested that doxycycline, when taken as post-exposure prophylaxis, is effective at reducing other STIs such as gonorrhea and syphilis. The CDC has now stated that doxycycline post-exposure prophylaxis, or PEP, may be an effective method for preventing STIs, especially when combined with HIV PrEP. Thus, although the efficacy of doxycycline PEP has yet to be thoroughly evaluated, there's emerging and consistent evidence that it may have significant reductions in STIs. I've just begun routine conversations with my patients about their use, about whether or not in their PrEP clinic they would like to also consider doxycycline as a strategy. Now, we as healthcare providers need to continue to monitor relevant clinical trials in this area, and as guidelines are surely important and going to change. Obviously, there's concerns around the microbiome and whether or not routine use of doxycycline as STI prevention could impact the microbiome, and whether or not that might have long-term implications for antimicrobial resistance, as well as anytime you impact the microbiome, you potentially increase risk of HIV infection. All theoretical, not proven, but things to be paying attention to. And when we think about PrEP and the various forms of PrEP we have, I think another key piece that providers need to understand and be prepared to address is the insurance coverage for patients seeking PrEP, because it remains a key barrier for many patients in terms of cost, not only of potential medications if they want certain regimens. Obviously, tenofovir diproxyl fumarate or Truvada is now available in a generic form called Teva and is relatively cheap for most patients. However, many patients, because of age, comorbidity, and other things, may be more likely to go to tenofovir alafenamide, also known as Descovy. And in that circumstance, prior authorization might be required. And I've had more and more patients ask me about long-acting injectable PrEP, and that certainly requires prior authorizations in most circumstances and an articulation of why that injectable PrEP might be right for this patient. Principally, that importantly comes down to describing inconsistent use of PrEP and having tried oral PrEP likely first in the cases that I've run across. However, the U.S. government website called Ready, Set, PrEP provides all the necessary details on assistance qualification. And I usually start with this site for my patients. And typically we can find PrEP support, if not for treatment alone, but also for covering therapeutic and diagnostic test and STI.
Thank you so much, Dr. Farley, and thank you to our listeners for joining in. As a reminder, to view the full program, please visit the PCE website at pce.is/prep. And as always, thank you for listening.